another trial that I think maybe you can speak briefly about is Sunrise 3. I don't know if you're a part of Sunrise 3, but that's also another area that's looking at BCG naive, right? So maybe for the listeners, can just help maybe understand what the TAR system is? And we'll go into it in the BCG refractory setting in a second, but for the BCG naive setting, there is a trial coming out. They're looking at TAR-200 in that area.
Yeah, absolutely. So, essentially, for the longest time after there was failure of BCG, we didn't have many viable options other than radical cystectomy. Valrubicin is a chemotherapy that was FDA approved in 2000, but it works very poorly. Less than 10% of patients have a long-term response, so it's not widely used. In the past 3 years, or in the past few years, we've had FDA approval of three agents: intravenous pembrolizumab, and then two intravesical agents, adstiladrin, which is an oncolytic adenovirus, and Anktiva, which is an IL-15 agonist that's combined with BCG. There's a few really promising clinical trials with other agents. There's other oncolytic adenoviruses like cretostimogene, and TAR-200 is a really interesting platform where there is a implant placed into the bladder, a small rubber catheter that kind of deploys in the shape of a pretzel. Um,
Mhm.
and inside it, there's small pellets of gemcitabine that slowly release over time. I think the release time is between 1 to 2 weeks. So you're having prolonged exposure of the urothelium to gemcitabine, much more than just the 1 hour placement that we usually do in the office. These agents are showing really promising results in the BCG unresponsive space. So the next natural question is, are they going to work nicely in the BCG naive space, especially when we're still undergoing a BCG shortage? So the Sunrise 3 trial is looking at that. And, I think as a community, we're really excited for all those results.
Yeah, I know, absolutely. And I think, I believe Sunrise 3 actually met enrollment. So I think they're just going to look for the readouts in the coming years. But you brought up kind of before we jump into the unresponsive setting, so I think let's just say I'm a patient, right? And I walk in, I have, let's say, TA high grade, and let's just say 5 centimeters, just because, I personally, I don't know, I can get your thoughts on this. Don't think size is a good surrogate for any of these stratifications. I mean, for me, size is irrelevant. For me, I treat all high grade disease as high risk disease. And I don't know if it's the same for you, but let's imagine I come in with high grade disease, and it's TA, so it's non-invasive, but it is to the first, it's non-invasive disease. So talk to me about the risk of recurrence, kind of what the long-term outcome for those patients kind of look like, just so that from a patient perspective, how does that look?
Sure, sure. Um, I think you made a really good point about tumor size. It's so subjective. We have some broad, tricks to try to quantify size objectively. The loop diameter is supposedly, a centimeter, so you try to measure how many loops,
Right,
but extremely subjective. I'll just leave it at that.
right.
Um, I think the stage probably matters more than the size. So if you have a
Mhm.
pure papillary tumor, that's going to respond different than a T1 tumor versus carcinoma in situ, or if you have multifocal disease with some of these mixed in together. And we're only just starting to really tease that apart and understand the differences. Traditionally, we've kind of just lumped in non-muscle invasive bladder cancer as one entity,
Yeah,
understand that CIS is especially more aggressive, but looking at pure papillary disease, I think is different than these other mixed populations. Um, as to, what are the outcomes of these different disease states? When you look at the historic BCG data, pretty consistently, the 2 year recurrence-free survival was somewhere between 60 to 65%. And I think a
yeah,
lot of us use that number. We say there's about a 40% chance of recurrence. Um, the newer studies, interestingly, show that patients are responding better to BCG now than before. And we've seen that in retrospective studies and some prospective studies that are out there. It looks more like the 2 year recurrence-free survival is closer to 80% now. Why is that? We're using the exact same BCG that we always have. My personal hypothesis is that we're doing a better job with risk stratification. We're
yeah.
probably doing better surgeries. We have new enhanced cystoscopy systems. We're routinely re-resecting T1 disease. So all of these things are responsible for better outcomes now than we used to see.
Yeah. I mean, I think you just kind of underpin that point that non-muscle invasive bladder cancer is not a homogeneous group of patients, right? It's such a wide range. It's very heterogeneous. And so I think we probably are better stratifying patients, whether that's leading to better BCG response or not, it's hard to say, but I think before we jump into the BCG unresponsive, refractory setting, what are some, or, what are the roles of kind of these new molecular profiling biomarkers, right? Like FGFR, PD-L1 mutations. That's something you use in the non-muscle invasive setting, in the BCG naive setting at all? Is that something that you routinely use in your practice?
Not yet. I think biomarkers are very needed in this space, especially as we're finally getting more options other than just BCG. In the past, when you only had one treatment option, the biomarker is really not going to impact your treatment decision other than allowing for better prognostication. Now that we're getting more potential options like gemdosi or some new combination regimens, it'll be a very useful question to answer: which
Yeah,
patient is going to work best for which treatment? Um, I am not routinely ordering testing like PD-1, FGFR, at least for
yeah,
high-grade disease. I think, there's some exploratory efforts with some of these companies looking at FGFR
yeah,
mutations for low-grade disease. So that's kind of a
right.
different entity. But for high-grade disease, I'm not using that. We are doing some research efforts looking at molecular subtyping for
Sure.
NMIBC. That's been explored a little bit more for muscle-invasive bladder cancer, but
Hmm.
those same luminal, non-luminal categories don't seem to work quite as
Correct.
well for NMIBC. So I think we need to develop new tests that are specific to non-muscle invasive bladder cancer.
Yeah.
Um, One test that I am starting to use, which I think there's a lot of excitement about, is artificial intelligence augmented histology
Hmm.
analysis. So, there's a few different companies that are looking at this, but we have some experience with the Vesta test. And this basically takes a H&E slide from the TRBT, zooms in at 40x magnification, looks for microscopic features that predict response to BCG. And we just published some new data showing that it can actually predict if a patient is more likely to respond to BCG versus gemdosi. So
Hmm.
definitely needs to be validated in a prospective fashion, but I think those types of biomarkers is where our field will move.